Okay, so I thought every time I have a session with you that I would try to put something up. Well, I'll come to that here in a moment. I think where we left off last was we had just looked at currents of injury, and we'd seen a few infarction patterns. And so I thought uh, we'll kind of pick up where we left off, not necessarily with the same topic, but I think that's where we left off. Um, any takers for this first tracing? And uh, perhaps I would ask that someone volunteer kind of quickly so we don't spend too much of time waiting on someone to volunteer. So just jump in and
ఇది QA infarction లాగా ఉంది. Inferior infarction లాగా ఉంది. Inferior infarction లాగా ఉంది.
okay.
The Dr. Jayachandran, wait.
I might be hearing some background conversation. I thought it was someone volunteering to speak, but let's get someone to just look at it and give us a diagnosis or the main findings on the tracing. Do I have a volunteer?
Yeah,
Otherwise, we can pick someone and we keep going.
So this is an ECG showing sinus rhythm in normal axis. There's Q waves in lead 2, 3, and AVF. So it looks like an inferior wall MI.
Okay. So, this is a typical being kind of led down the garden path by someone who's trying to get you to trip up on the EKG in front of you. But remember that the reason I'm just not doing classes with sessions of we're going to do all atrial fibrillation flutter today, we're going to do heart block tomorrow, we're going to do MI the following days, because in real life just throws you up EKGs at random. And so if you're reading, you're going to come across this tracing suddenly. So it does look like these, what look like Q waves here, but are they really infarction Q waves? Look at this complex here now. Focus on V3. Now, what do you think? Any thoughts, any change of heart? Look at the P wave there and look at the QRS, and what do you make of that?
There's a delta wave at the...
Very good. Yeah, good. So you have a almost non-existent PR interval. It's just a very quick onset of the delta wave and leading on into the QRS. So in fact, pseudo-infarction or delta wave pre-excitation, ventricular pre-excitation. And just to refresh, what is a delta wave, just to remember. And it's a good thing to refresh this concept because of what it means with different levels of pre-excitation and as to where accessory pathway may be located. All of these things we're going to discuss over time as we look at tracings. But today, let's just think about one thing. Each delta wave is a fusion beat. By that, what do I mean? A fusion beat is every time you have activation of the ventricle from two different sources. So here, if you think about it, you have normal activation coming down the AV node and then spreading through the normal conduction system into the ventricle. And you have activation as soon as the atrium is activated. Remember, the entire atrium is activated here within 50, 60 milliseconds. Most of it is activated. You certainly have activity over here over in the left atrium if this was a left-sided pathway. And immediately activity starts, so electrical propagation starts going down this pathway. And you begin to have two different wave fronts. You have activation of the ventricle from the normal conduction system, and you have activation of the wave front of the left ventricle or the ventricle, whichever ventricle it is, from the accessory pathway. So when these two wave fronts collide, you get a fusion beat. By collide, all I mean is that the ventricle is, in summary, activated by both the delta wave, by both the accessory pathway and its pre-excitation, as well as through the normal conduction system. So each beat is a fusion between normal and abnormal conduction. You could well imagine the same thing could even happen if you had a PVC from this spot firing. But for now, we're dealing with pre-excitation. For every single beat, you have fusion with conduction going down the normal pathway, as well as the down the accessory pathway or a pre-excited beat, pre-excitation here. Now, so just to keep in mind, pseudo-infarction Q waves, non-infarction Q waves in bundle branch block, WKW, LVH, infiltrative processes, or some specific situations where you may have positional change. And we'll see some of those examples. If I'm going too fast with anything, would someone please speak up and tell me to slow down or repeat it, okay? So to think about pre-excitation and thinking about, well, where is this pathway? Is it on the left side? Is it on the right side? Is it anterior? By anterior, we always mean on the superior aspects of the ventricle, the anterior surface of the ventricle, or is it inferior? What you might think of as inferior and posterior. Kind of a very approximate or a rough way to look at it is look at V1, and if there is a positive delta wave and QRS in V1, then it's a left-sided pathway. And if it's negative in V1, then it's a right-sided pathway. What's an easy way to remember this? Simply very similar to bundle branch block. That is, at least the concept of bundle branch block, which is if you have a left bundle branch block, your left ventricle is being activated like, no, perhaps that might not be a good example. Let's think of PVCs. If you had a PVC originating in the left ventricle, then you would have a positive on the left side. And so V1 would be positive for a left-sided pathway and negative on the right-sided pathways. If you looked at pathways as whether they're anterior or posterior, if they are anterior with activation proceeding towards the feet, then you would have positive QRS, positive delta wave in the inferior leads. And if it's negative, that means it's going away from the inferior leads. And so it's going to be then inferior or infra-posterior pathway. So anterior pathways will be positive in the inferior leads and posterior pathways negative in the inferior leads. If you had a strongly positive delta wave, and in fact, the faster this person's heart rate would go, you're going to get a taller and taller complex here in lead V1. And all of the late activation is coming over towards, all of the activation is coming over towards the right ventricle from a left-sided pathway. From left towards right would be the axis, or would be the vector of propagation. And so you would get positive in the right heart leads. So the right heart leads V1, V2, looking at the right side of the heart would see the vector of propagation coming towards it from a left-sided accessory pathway. And so if you looked at this tracing here, what do you make of this now? Any comments? Same person can, who read the prior one, can take a quick shot at this.
There's a negative delta wave in V3.
Yeah, perhaps you said in V1. I think the audio wasn't completely clear. So, but so in V1 you have a negative delta. In the others you're positive. Here in the inferior leads, so we know it's an anterior pathway. So I think I'm going to have to revise what I said, and probably you're all going to have to turn your audio off except for the person who's speaking, because I think there's a bit of feedback and some background noise. So I apologize, but looks like our little experiment didn't work with that. So let's have you all turn off your audio, except whoever's very kindly volunteering to speak up. So one more example of ventricular pre-excitation, WPW. Remember, the WPW syndrome is actually a syndrome of atrial fibrillation and ventricular pre-excitation. So if you're reading this in the heart station, I would say this is sinus rhythm with ventricular pre-excitation. And that's all you need to say, sinus rhythm, ventricular pre-excitation. I thought I'd do at least one tracing each time I met with you all of something that someone just gave me that week and said, hey, what is this? So I get that all the time because I work with a group of cardiologists. So I have other people, other cardiologists or people working with me just hand me an EKG and say, hey, what's going on over here? So I'm going to do the same thing to you. So every time they ask me something, I'll bring it up and show it to you. So let's have someone else take this one and let's have some comments.
David, would you like to take this?
Just continue. Yeah, it will take a while, but you can still continue.
Do we have a volunteer? Audio is a little soft. If you could speak up.
Yeah. So, is it showing a sinus rhythm, sir? With,
Very good. Good. Yep.
Hi.
there is a an ST segment depression in one and AVN.
Good. Good. Yeah. So you've got some ST segment depression and kind of an odd-looking ST segment depression. You think?
Yes.
Do you think anything special about this? It looks kind of different from the usual ST segment depression you see. Any thoughts? I'll tell you what. Just a week, 2 weeks before, this was the same patient's EKG, ECG. Look at that, and then look at that now. Some change in just over two to 3 weeks. 2 weeks, I think this was 2 weeks apart. So odd-looking ST segment, really saggy. You know, I would call it kind of a sagging ST segment. So that was a tracing of about a 78-year-old woman who'd been sent home on a combination of amiodarone and digoxin. And I think she didn't really follow the instructions. She was given digoxin by one of my colleagues at 3 times a week. She took it every day. And I think amiodarone, she took double dose. So that's a great combination for this digoxin toxicity. And, you know, you have this sagging ST segment, classic for dig toxicity. You know, this is like the, it's supposed to be the inverted handlebar mustache of Salvador Dali, this artist guy. And look at that. That's really pretty good for this one, wouldn't you say? So, so dig toxicity. I'm sure it's going to appear on someone's exam somewhere. So keep that in mind. Just that I was handed this EKG this week, so I thought I'd put that up for you. The QT gets shorter, and in fact, on her admission EKG, she came in with nausea, vomiting, and all dig toxic symptoms, and she had pretty solid U waves as well at the end of the T wave, and I'll show you some examples of that another time. But that the tracing that this patient had this time was kind of really poor quality, so I didn't bring that one for you. Okay, let's switch gears and take a look at different tracing here. volunteer, please.
Vityara, would you like to comment on DC?
So this is a ECG which is showing a few VPCs along with the normal QRS complex. It's a sinus rhythm ECG with a
Sinus
rate of
rhythm.
around,
Okay.
with a rate of around 70 to 75.
Okay.
With between few large QRS complexes, probably it's a VPC.
Okay.
And the axis is normal axis lying between 1 and AVL.
Good. Anything else?
Is there a ST elevation B1, B2?
Good. So what are you calling that? Or do you have a comment on that? Or do you want to make that a
Probably
part of the diagnosis?
It's probably ST elevation MI.
Okay. Good. Good job. I'll kind of take it from there. So I like how you read it. It's sinus rhythm. It's got some wide complex beats, maybe PVCs is what you call it, VPCs, and anteroseptal. So when you have changes in V1, V2, V3, you agree? It's all the way up to V3 and maybe even heading out into V4. We're going to call this both anterior and septal, correct? We'll call this anteroseptal changes. Anteroseptal MI, is it acute with current of injury? There is ST elevation here, I agree with you. A little bit,
deep Q wave.
yeah, a little bit atypical in that the ST segments are not, just kind of coved upwards, so to speak, and you don't have any dramatic reciprocal changes or as prominent as those look. So maybe it's not acute. The fact there are Q waves, you do know that. I know someone said there's in the background Q waves, but you do know that at presentation of acute infarction within the first few hours, you can develop Q waves. So just because there's Q waves doesn't mean it's not an acute infarct. But current of injury is definitely present. Reciprocal changes, not so sure. I wouldn't say they're very prominent. A little prominent on the voltage, kind of a little suspicious for LVH possibly. And we can look at some LVH criteria here in a moment. And then here are these big white beats over here. And what do you make of this beat here?
It is not arising from the SA node, it's the shortened PR there.
Good.
Probably it's a ventricular origin.
Yeah, good thought. Good thought. Maybe ventricular in origin. So, but what's interesting is, look at this beat here, and look at this one. Why is this, if this is a PVC, why does it look so skinny? So let's, I won't beat you up on this, but you were really good to point out that, look, this PR interval is just not normal. It looks kind of short. Not quite sure, did this really come from this P wave? Maybe, maybe not. It still probably did have some time to conduct down. So my suspicion here is that this is a fusion beat. Some conduction down the normal conduction system, and some of the ventricle captured by the ectopic. So again, a fusion beat is one where the ventricle is captured or depolarized from two different sites. And in this case, different from ventricular preexcitation that we saw the delta wave example on the first tracing, here you have conduction coming down the normal pathway, coming down the AV nodal system, as well as conduction or propagation through the ventricle coming from the ectopic site or ectopic spot, the PVC. What's a good way to tell? Look at this QRS complex, the full kind of, let's say, unadulterated PVC, and then look at your normal QRS complex as it conducts down the usual conduction system. And I think you'd agree with me that this is kind of a mishmash or a combination of this one and this one. If you could add up that and that, you're kind of going to get this, which is in effect what a fusion beat is. And I'll talk about LVH here in a second. But if you think about fusion, let's see here if I've got a fusion. Okay, here's a good one. So we use this in EP, we use these ladder diagrams a lot, but they're really very nice for looking at the basics of any arrhythmia whatsoever. And a ladder diagram is real easy. It's just basically atrial activity, AV nodal, and then the QRS, and the QRS corresponding to ventricular activity. And this is good because it helps you think about timing relative to what you're seeing on the surface, timing. And timing is really crucial. So if you have a PVC might even conduct retrograde. So this one fires in the ventricle, goes up back through the AV node, and in fact captures the atrium here, and you get a small negative P wave here. Not that prominent on this tracing I'll give you, but it's there. And so this is a retrograde conduction of a P wave from a fully captured ventricle just from the ectopic spot, ectopic site. What happens here on this beat? You have atrial activity from the sinus node, like you said, kind of a shortened PR interval, because while it's making its way down and has just entered the ventricle from the normal conduction system, almost at the same time, the PVC has fired. And this collision between the normal conduction and the PVC causes this fusion beat. So let's get back to that for a second. So here's our fusion. This is not just that esoteric. I'm not trying to make a very theoretical point of this. These are very helpful beats to pick out whether wide complex tachycardia strip you're looking at, whether it's VT or SVT with bundle branch block. These are going to be incredibly helpful to look at later when we're looking at those wide complex tracings to decide site of origin of that beat. So PVC or VPC and normal conduction and a fusion beat. There's something else going on kind of interesting here, which is this focus. This PVC seems to be firing all over the place. Look at the relationship between QRS and the PVC. It's long here, it's probably short here, it's very short here, obviously. So you got to get a little bit suspicious that this could be what you call a parasystolic focus. That just means, it's just kind of a big word for saying there's a very protected focus of a PVC sitting there in the ventricle, and it just fires, and this is obviously going to be the firing interval of that PVC from here to here. And whatever this conduction system does, it's not able to penetrate and reset that focus. And that's why it always fires on time. So then you're going to ask me, why didn't it fire here? So you walk this back. If that's that beat, if that's the interval of the parasystolic focus from here to here, then the next interval is going to fall about here. and then the next interval about here. So one might ask, well, if you just made a case to say that this special condition called parasystole means that a PVC focus is protected and keeps firing at its own rate, kind of unhindered or unimpacted by the conducted complexes, why did it not fire here? Well, it did not have a chance because the complex, the ventricle was already refractory, because you have a normally conducted beat here. If you measured in timing, the PVC should have fired exactly here. But once it comes out of its little cellular zone that it's firing out of, what is it going to find? It's going to find that the ventricle is refractory. It's already all done. And you remember what refractory period is. What's a good way to conceptualize refractory period? No more complicated than a flush tank. You flush once, you've got to wait till you flush again. So think of that as your refractory period. So you have QRS here firing from your PVC focus. Next one should have fired here, did not get a chance because it was, the ventricle is refractory. And then this one fired, again, the PVC focus fires, the parasystolic protected focus. But part of the ventricle is captured by this PVC focus, and part of it is captured by normal conduction, the fusion beat. And here the ventricle is not refractory, and conduction has been completed from top to bottom through the normal conduction system. And the ventricle finds itself available to be depolarized by this PVC. And so you get a full-blown PVC right there. So it's a really pretty example of parasystole in the setting of structural heart disease, which is almost where always you find it, in the setting of significant LVH, bad valvular disease, significant coronary disease, because you have little fibrotic islands of tissue around these spots which are firing as PVCs, parasystole. So you can kind of maybe try to stump one of the cardiology trainees with that next time you see one. So LVH, we wanted to talk about a little bit, is just here, I just put this in as a reminder to myself. If you have left ventricular hypertrophy, all your left-sided leads, V5, V6, 1, and AVL, are going to see a dominant activation coming towards them. And so you'll get all these prominent leads here, and activity going away from V1 and V2. So you'll get dominant negative in V1 and V2. The opposite with RVH, where V1 and V2 are looking from the right side of the heart, and they're going to see a very prominent R wave in V1 in right ventricular hypertrophy. So left and right ventricular hypertrophy. I'm not going to dwell on criteria. It's very easy for you to open any textbook of cardiology or EKG book and take a look at it. This one's quite easy, this STs, even though it looks like multiple criteria. It's not that hard to remember. Remember that, if you have significant voltage, and that's 30 millimeters, if you were to add up the S and V1 and the R and V5, or V2 and V6, if you just add up the S and the V and the V, and you get to more than 30 millimeters, you're going to get 3 points. If you have, I apologize, someone's going to have to get themselves on mute if they're speaking there. And these are reciprocal changes, basically changes in the opposite direction from whichever way your QRS is pointing. So if you have QRS pointing positive, and you have discordant change, which is the STT going in the opposite direction, then these are called secondary STT wave changes to the prominent voltage of ventricular hypertrophy. So you add that voltage and that voltage, you get more than 35 millimeters. And another really helpful one is this Cornell criteria is pretty good as well, where you add up the S wave in V3 and AVL. And if you hit 30 millimeters in anybody, it's good for LVH, but even more than 20 millimeters in women. Remember, each millimeter is 0.1 millivolt. And that was our example from before to just think about fusion. Okay, next volunteer.
Susan, are you there? Susan, can you take this?
Yes. So this is a ECG. It's showing a sinus rhythm. It shows normal axis. I'm able to see in the QRS complex there's predominant negative deflection in waves, in leads V1, V2, and V3, and as well as in V4, the QRS complexes show predominant negative deflection.
Yes.
Whereas it is predominantly positive in leads V5 and V6. So they may be more indicative in terms of RVH, but if the exact criteria are fulfilled, I just have to check. I'm also able to appreciate complete T wave inversions in V5 as well as V6.
Okay, good. Yeah, good shot. So let's look at this here for a second here. And when you look at hypertrophy, remember that when the left-sided leads, which are 1 AVL, V5, V6, you remember 1 and AVL are like the left arm lead, and V5, V6 look from the left side of the chest. Remember, V6 is over in the mid-axillary line, looking from the left side. So when you get prominent voltage there, then you're looking at left ventricular hypertrophy, and you get a dominant going away from V1 and V2, then that's consistent again with the left ventricular hypertrophy. So, so this prominent voltage here being in the negative direction says, okay, the ventricles is depolarizing away from V1 and V2. And remember that V1 is down by the 4th interspace on the right side, just in front of the right ventricle. Remember, right ventricle is anterior and the left ventricle is posterior and leftward. Right ventricle is anterior and rightward. So you have voltage going away from lead V1 and V2 and towards V5, V6, 1 and AVL. And so this would be, if it, and I do believe it is ventricular hypertrophy there, because you have the criteria met here with deep voltage as well as opposite direction STT wave changes, what we call secondary STT wave changes. Now, any tracing you're handed, I think it's always a good idea, like you said, you started talking about the rhythm. When you look at rhythm, never base your decision on what the rhythm is on just looking at one lead. Any ideas which is the best lead to look at rhythm? Just as to what the underlying rhythm is whether there's a sinus mechanism or not. I'll tell you, it's always going to be V1. And the reason V1 is so helpful is because it's sitting right in front of the right atrium. The atrium, the right atrium's anterior there, and it's kind of taking a good look at both atria, both at the anterior and posterior atria. The anterior being the right and the posterior being the left atrium. And so always very helpful, and especially if someone is very kind, like I am here, of course, and giving you a long strip of V1, then you must take advantage of that. So if you look here carefully, and you'll need calipers for this, and look at this here, and don't you think this is a little odd? It's a bit of a long PR interval here, and then you've got something going on over here. So is this part of the QRS complex, or is it is it truly is it just another P wave hiding in there? What is the best way to tell? I'll tell you the best way to tell is going to be to take your calipers if you have, or you know, any measuring device. You can just take a edge of a piece of paper and put 2 dots here. Put it exactly on that and exactly on that, and that's going to measure exactly to that, as it would to right there. Even if it's a little bit off, then you know, okay, this is just an R prime part of a QRS. But if when it measures exactly like that, you have to be mighty suspicious. And it was true in this case that this is in fact a P wave right here. And if this is a P wave, then what are we dealing with here? 2-to-1 conduction, right? Every other P wave is conducting. This P wave blocks, this one conducts to QRS. This P wave blocks, this one conducts to QRS. And what is the atrial rate here? Let's see, what's a good one here? Let's say 250 milliseconds maybe. That's 200 milliseconds. Another big box, another 5 millimeters would be 400 milliseconds, and this is somewhere in between. So maybe even coming up close to 300 milliseconds, 280, something like that. So just under 300 milliseconds from P wave to P wave. So we would call this a atrial tachycardia or atrial flutter. I'd give you, you know, full marks for either if you called it an atrial tachycardia or an atrial flutter with 2-to-1 conduction and left ventricular hypertrophy with secondary STT wave changes. So always look in lead V1 and see if there's anything suspicious there, especially when you see kind of an odd situation here where, wow, that just doesn't look like a normal PR interval. There's a lot going on in there. There's a positive, there's a negative deflection. It kind of looks like it's almost sloping into the QRS. Not the easiest, but when you look down on this longer strip, you can see the pattern that it's 2-to-1. Actually, let's go to, okay, let me see here. Yeah, let's take this one and then we can come back to more of those rhythm EKGs. Any takers here?
Usagre, can you take this?
Yes, sir. So this is a ECG showing sinus rhythm because every QRS is followed by P wave. The rate on this ECG is around 60 beats per minute. Axis can see both positive and negative deflection in lead 1 and AVF, and predominantly negative QRS in V2, V3, V1, and also V4, and positive QRS from V5 and V6 leads. So probably a left axis deviation, but I'll have to see if it meets the criteria. Apart from that, other things that can be observed here are that there are T-wave inversions across all the V2, V3, V4, V5, V6, lead 1, lead 2, and lead 3, and a positive T-wave in AVR lead. So,
Yeah. So I think this was not one that I wanted to dissect very deeply, but I just wanted to just kind of give you a tracing like this and say, you know, what are you suspicious of if you're handed this EKG? What's a kind of a clinical diagnosis what is a clinical diagnosis that might cross your mind when you see this kind of, obviously we're looking at giant T-wave inversion, right? It's enormous T-wave. So maybe electrolyte abnormalities, good, yeah. So electrolyte abnormalities can cause some T wave changes. We'll talk about them more, but remember that it's more to do with the ST segment shift with potassium shifts, with hypo and hyperkalemia. When you get this dramatic T wave inversion like this all across the precordium, there are actually very few things that can do it. You can get pretty dramatic T wave inversions in acute ischemia. I'd give you that. But this one's really diffuse. Look at it, it's in every lead. You have a giant T wave inversion. And this is almost always what you always need to rule out in this situation is a neurologic cause, like a subarachnoid bleed or something like that is where you would typically see this kind of giant T wave inversion. This is a neurologic EKG. This is the one that you'll see in the neuro ICU. More than in the CCU, strangely. So even though it looks that dramatic. QT interval is also prolonged, which I'm not sure if you mentioned that, but the QT is prolonged. You see how long the QT interval is. I'm not going to go based on measurements here, but I'll tell you a good rough rule of thumb here, which is if the QT interval is greater than half of the distance between QRS to QRS, then you're going to be suspicious that it's long. And here you could see it just about crosses that. The QT probably ends about here. And that's, if you were to go half to half, it'd probably be right about here. So this QT is long. It's a little even longer on this lead, more prominent. Remember that QT intervals will look different on different tracings. Could this be long QT syndrome or a channelopathy? It's a little odd or unusual for that. We'll see some examples of that. So I'm really suspicious here of neurologic injury, typically with bleeds. Head bleed will give you this, subarachnoid bleed. I think that was just a reminder on hypertrophy. Okay, well, good job. Thank you for taking that one. And I appreciate everyone being sporting and taking some, taking on the EKGs. So let's go with this one.
Shreya, would you take?
Yes, sir. This is a ECG showing a sinus rhythm. The rate is regular. Rate comes to around 40 per minute. I'm seeing a few broad QRS complexes in lead 1, V1, V2, and V3. I'm also seeing a biphasic T wave in V2 and V3.
Okay.
Also, sir, in terms of the so I think I'm seeing a U wave also in the last three. I don't know which leads they are. In the last three sections, I'm seeing a U wave as well after the T.
Okay, yeah, I apologize. That's V5 out here, I think. One of those. Yeah, looks like V5, V6. So. Okay. So, yeah, well, yeah, good shot picking out that you have, really wide complex. The ones that I'd go along with you are these are wide complex beats right across the screen. It looks like you're dealing with What do you make of the white complex? Any thoughts on that? Okay, so we'll talk about the QRS complexes here in a moment, but I want to kind of back up just a little bit. So you did say the rate's slow overall, and it's 40 beats a minute. I agree with that. So what should you be suspicious of as soon as you see, wow, what is this doing at 40 beats a minute? You must start looking and thinking about, well, are all the P waves matching up with QRS complexes? Are there more P waves than QRS complexes? Which are the P waves? Which are the T waves? Which are the U waves? And don't make it too complicated. Remember, I always said, look at V1 to decide where your P waves are when you're thinking about rhythm. And you called it sinus, and it is sinus rhythm. Looks like a normal looking P wave. In V1, it's positive and negative. Biphasic P wave in V1, so it's a normal sinus P wave. It's not AFib, it's not atrial fib, it's not flutter. It's a sinus mechanism. So I'd agree there's a sinus mechanism of a P wave. And I think you call this little hump out here after the T wave a U wave, and that is where a U wave would be. I'd agree with that. There's a U, that is where a U wave would be. It's a little more of a separation between T and U than we would normally see. You can see here there's a pretty solid isoelectric line. It's a little uncommon for it to be that long, and so maybe not a U wave. But come back here and look at this thing now that we call a U wave in the other leads. Doesn't that look suspiciously like the P wave?
Yes, so
yeah. So if
so
you look
it's
at
not
that,
conducting after that.
exactly. Very good. So basically you had a P conducting down to QRS, P block, P conducting to QRS, P block. So we would call this 2-to-1 conduction, right? Every other is conducting. So what do I mean by 2-to-1 conduction? Look at the conducted beat, look at the number of P waves, around it, and this one conducts, this one blocks. That's 2-to-1 conduction. Okay. Now, why is this blocking? You know, what's going on over here? Why are the QRS complexes wide? So when you see this wide complex in 1, AVL, V5, V6, you must be suspicious that there could be underlying bundle branch block. And so that's in fact what this person has, which is a left bundle is blocked, right? When you're looking at, and I'm going to show you an example of why that's so. Let me see if I can find you my slide on that. Oh, okay, good, perfect. So classic left bundle branch block over 120 milliseconds. You get a broad monophasic R wave in lead 1, V5, V6, and absence of Q waves in those same leads. And a couple more points. I'm going to talk about that here in a second. Why does that happen? You get conduction. I'm sorry, did someone have a question? Okay, you have conduction that goes normal from sinus node to AV node. And then once it works its way down into the septum, remember that normal activation is left to right. But if you have the left bundle branch blocked, then activation of the septum is right to left, okay? So when you have this right to left activation, what you have is when you're looking from the left-sided leads, what you're going to see is normally, in the normal situation with a normal EKG, you will see left to right activation of the septum. You'll see a tiny Q wave in lead 1, AVL, V5, V6. In left bundle branch block, those Q waves in lead 1, V5, V6 will be absent. That's one feature of left bundle as to what's going on in the septum. And then as conduction progresses through the left of it, what happens? The right bundle is working just normal and fine. So septum depolarizes right to left, and then you get propagation in the right ventricle. And so you have the right ventricle being captured or depolarized. And then you have this large unopposed force going through the left ventricle. So it's muscle to muscle conduction. Instead of going through the his Purkinje, the entire left ventricle is being depolarized by muscle to muscle conduction. And what does that do for us? It gives you a dominant in the lateral leads. You get this delayed or slurred large monophasic QRS complex in the left precordial leads, because the left precordial leads are looking from this direction and they're seeing the left ventricle being depolarized late. And why is it being depolarized late? It's because instead of the very efficient God-given conduction through the His-Purkinje system, which goes at 10 times the speed of muscle-to-muscle conduction, instead you have muscle fiber to muscle fiber conduction, slow and capturing the entire left ventricle. And at that time, when the LV is firing or being depolarized, the right ventricle has already completed its activity. So all of this action here on the left side is unopposed, which is why all the left-sided leads see this huge vector coming right at it, and you get this big positive QRS coming at it, or this delayed, slurred QRS part. This portion of it is all the left ventricle being activated. And similarly, the right heart leads looking from V1, V2 will see the QRS complex going away from it. So you get negative QRS complexes in lead V1 and V2. And the other is that ST-T wave changes are discordant in that when you have QRS, downsloping QRS here in V1 and V2, ST-T wave are in the opposite direction. And similarly here, if you have positive QRS, you'll get the ST segment actually sagging downwards instead of going positive. So, and you have a QRS width of 120 milliseconds. Remember, each little box or millimeter is 40 milliseconds. So if you make 3 of those little boxes, it's going to be greater than 120 milliseconds. And so anything over 120, you have your wide QRS. Delayed intrinsicoid deflection is the other feature, and that's basically from the onset to the peak of the QRS, you have kind of a slur here. And so in the left-sided leads, looking at the ventricle coming right at it, the LV being depolarized, you have the slurred activity coming towards it. And so you have slurring on the upstroke from the beginning to the peak of the QRS. That's called delayed. It's a fancy word just for saying slow activity across the left ventricle coming towards it here. Delayed intrinsicoid deflection. Now, one feature I really want you to look at long and hard is that look at V1, and you should never forget this. In a typical left bundle, QRS onset in V1 and V2, it is a very sharp downstroke. It's very sharp and very straight down with no significant QRS complex, always less than 30 milliseconds here, this QRS. It's a tiny little quick blip upwards, and then you get a very sharp downstroke because whatever it is, a large portion of the heart still being activated using the normal conduction system. And then you have the His-Purkinje still working on the right side of the septum. And that's why you get this fast downslope here. And that's very important later when we look at wide complex tachycardias and trying to decide, well, is it bundle branch block or is it VT? So imprint this pattern on your brain, the typical left bundle branch block. Would we tell our medical students, rabbit ears, boom, boom, in the left precordial leads in lead 1, AVL, V5, and V6. You get a big negative downstroke in V1 and V2. You get a very sharp downward deflection. You have loss of Q wave. Look at this, V5 and V6. Normally, there's a little sharp little Q wave followed by QRS. And in these, this is lost. I'm down to the last 1 minute of our time together here. And here, of course, you have 2-to-1 conduction. Long story as to why we didn't call this, so is it second degree type 1 or type 2? Cannot say. It's 2-to-1 conduction. And that's a long story for another day. Well, that's a story for another day. I'm not sure that it's a long story, but it's a story for another day. But so 2-to-1 conduction and left bundle branch block. What about axis? You can see here you have a negative QRS complex in lead 2, positive in lead 1, and negative in all of the inferior leads, in fact. And so this is going to be to the left of negative 30, since lead 2 is negative. And so this will be a left axis deviation as well. So looks like we're going to have to wrap it up there on your time schedule. And so I'm going to stop right there. Any questions? Anything I can help you with or recap?
If you have any doubts, you can either ask now or you can put in the chat box. Or you can also mail to us on our department mail, medicine2@cmcvelu.ac.in.
So why should bleeds cause any abnormalities in the, as in the waves?
Sorry, what was the question? Why do you get the abnormality in the QRS
Intracranial bleed.
complex?
Yes, sir. In the
Why do
intracranial.
why do the bleeds cause it? Oh, no one knows. No one knows. There's a lot of autonomic changes that go on with the obviously with intracranial bleeds. There are autonomic changes, and the autonomics are what control repolarization, and that's probably the underlying mechanism. But there is no clear, I certainly don't have a channel mechanism for you. Isn't any other questions? I'll sign off and let you guys get to your next class.
Thank you very much, Vijay. Next week, same time, same place. Okay.
Yeah, I think I should be able to. I think I have a busy weekend. I'm not 100% sure about Tuesday, but for now, I think. Well, you know what? Let's keep it. Let's keep that. I think it should be good because there's a lot of tracings I had today that we didn't get to go through, and that will more than make for next Tuesday's session. Yeah.
Wonderful, wonderful. Thank you, Vijay. We'll see you again next Tuesday. All right.
Thank you all.
Okay.
Okay.